Welcome to ASUG 2018 Bhubaneswar. I am Dr. Shahu Ingole and you are watching me live on MQR ASUG TV. I am glad to have with me the renowned gynecologist Dr. Shobha Gudi ma'am. Ma'am is the professor and head Department of Obstetrics and Gynecology, St. Philomena Hospital, Bangalore. Ma'am is also the president-elect for Bangalore Society of OBG. Ma'am is also the scientific chair for ASUG 2019. So welcome to the show, ma'am. Ma'am, based on your recent talk in the ASUG Bhubaneswar 2018, to improve the outcome in recurrent pregnancy loss, what is the role of uterine surgery and are there any evidences to support the surgical management?
Well, hello everyone. Let me thank you for the kind introduction. You have asked a very relevant question. In today's practice in gynecology, this becomes very important because with the advent of endoscopic surgery, hysteroscopic surgery and imaging sciences, uterine anomalies do get detected very easily. In the background of recurrent pregnancy loss, however, there are very few indications for corrective surgery. In fact, septal resection in cases of uterine septum is the only surgery perhaps which has supporting evidence to some measure, to some extent, to say that septal resection will help in improving the outcome. The other anomalies like bicornuate uterus, uterus bicornis, didelphys, arcuate, all these anomalies, there is no need for a corrective metroplasty even in the background of a recurrent pregnancy loss because evidence says that it does not help in improving the outcome. So that is as it stands according to many regulatory authorities, including the recent recommendation by ESHRE in 2017.
So, what is the role of molecular karyotyping in the management of the early recurrent pregnancy loss and what is the future?
Yeah, that is a very focused question indeed. Many of the early recurrent pregnancy losses are due to chromosomal anomalies. All of these are not possible to detect easily because most often when we say that the karyotype of the abortus has to be done, we get non-viable tissue which does not grow well in the culture medium. Therefore, I think it's important to realize that there is a higher investigation available, the array CGH, the genomic hybridization, the composite genomic hybridization. Now this technique will tell us the finer anomalies, the chromosomal defects of small deletions and translocations, and in such couples there will be a chance of occasional live birth, but the majority may end in an offspring which has got a major defect and therefore results in a miscarriage. Very important to now understand that such couples need to go through probably pre-implantation genetic diagnosis before we can make any difference to the pregnancy outcome.
Are there any autoimmune causes for recurrent pregnancy loss?
I think the doubts in such matters have finally come to a rest with the current evidence. Now, immunological causes of recurrent pregnancy loss can be either autoimmune or alloimmune. Autoimmune causes have been well identified and there is very good evidence today for treatment of such conditions. Your question, however, pertains to the alloimmune causes. There has been a huge amount of research and treatment protocols in such cases, and now finally we know that whatever was done earlier like paternal leukocyte administration to the mother or lymphocyte infusions, cytokine diagnosis, etc., HLA typing of couples to find out whether there is any problem. All such investigations are of no use in today's practice, and we should not test couples for these investigations at all. We should not be doing because it does not result in improved outcome for in terms of a life take-home baby rate.
Lastly, what is your key message for the practitioners who are managing the cases of rigorous pregnancy loss?
I think the key messages will be three, and the first and foremost, that most often the couples come to us in between their losses. This will be the time to investigate them thoroughly, and then a preconceptional counseling is of utmost importance, which is often neglected. So that should be a very important step, depending on the cause identified and the probable, presence or absence of therapy which is possible to offer to the patient. That is important. The second important message is to cut down on the investigation list that we offer to these. As discussed just now, we must make a protocol for our patients depending on affordability, accessibility to such investigations, and carefully choose which ones to do so that the cost remains limited, because as we know, many of the investigations have no use today. The third most important one is related to the treatment, and it needs to be very targeted. Unnecessary treatment can only expose the couple to higher cost with very little benefit, most often no benefit, and therefore treatment modalities like low molecular weight heparin or corrective surgeries, or as we discussed, lymphocyte transfusion, etc., should not be offered because to couples who are not, where it is not indicated. For example, low molecular heparin is indicated only in a very select group of patients in recurrent pregnancy loss where there is an identified autoimmune etiology. So we need to very carefully filter down the treatment modalities and offer the correct therapy to the women in order to get the best outcome in the most cost benefit way, because we must keep in mind that a vast majority of our patients belong to the lower socioeconomic class, and we need to keep the cost less. Those are the messages.
Thank you so much for such an informative discussion and throwing the light on the management of the recurrent pregnancy loss. Thank you.